meeting. In this meeting, our speakers are from Ukraine, from National Children's Specialized Hospital OHMATDYT. We thank all of them for accepting our invitation and joining us tonight. Now, I yield the floor to Ali.
Thank you, Berna. And it's a hello, everyone. Привет, merhaba. It is a pleasure tonight to invite our friends from Ukraine. And they are actually doing a great job in Ukraine. They are working in the best pediatric hospital in Ukraine, in Kyiv. I know them very well. They invited me before COVID to their hospital. I visited their hospital, and I know that they have a wonderful team here. First, Dr. Stanislav Riebienkov, he is the head of the department. He will start first. Then we have three other radiologists from the same department, Anastasiia Rusyn, Katerina Rusilo, and Daria Varyvoda. They will be showing us some interesting cases from their center. And I will be moderating the session. We will get questions regarding the cases after we complete each case. And I'm pretty sure we will have a wonderful night tonight. They told me that presenting in English was a challenge for them, and I told them for us too. We understand, but it's difficult for us to speak. Same here, but since we don't speak Ukrainian and you don't speak Turkish, we have to do it in English. And hopefully it will work well because we speak a common language, which is radiology. And one of the other objectives of this meeting is to create bridges between Ukraine and Turkey. And that's why we are doing this meeting. And thank you for accepting our invitation and giving us this talk. And now you can share your screen and start, Dr. Riebienkov.
Okay, I start to share my screen. Okay. So, do you see my screen?
Yes, yeah, I can see it very well.
Oh, thank you. So, hello everyone from Kyiv, Miraba. First, I want thanks to Dr. Ali for the invitation and great job preparing the meeting. Also, I want to thank our Dr. Daria Variwada, who realized this opportunity. My name is Stanislav. I am pediatric radiologist, and today I, with my colleagues, want to present some interesting cases from our work. But first, I would like to say some words about our clinic. Our hospital has more a century history. It's represented by a complex of buildings of different ages. With total more than 700 beds, provides assistance to children from all over Ukraine and from other countries. There are many departments and different clinical profiles. The main directions are surgical and oncological. Also, partially, our clinic performs functions of university clinic. The new building is being equipped and several old buildings are being renovated. Our big radiology department is a large and mostly young team, consists of radiologists, ultrasound specialists, radiation therapists, nuclear medicine doctors, etc. Also, more than 30 technicians, laboratory assistants, physics, engineers, at all. I will show you a few photos of our team. Here we see that we have some CT, many Röntgen, many X-ray machines, Linac, some 1.5 Tesla MRI, and we perform radiation therapy, and in future we we will launch a hybrid molecular imaging unit. Various educational events are regularly held on basis our hospital, and we invite everyone to join. Follow the announcements on the Facebook page of our department. So let's move on case that have surprised us. The first case concerns prenatal MRI. We have been doing prenatal MRI quite recently, and we actively studying information in this area. Pregnant woman was referred for MRI at 21 weeks with suspected fetal neck lymphangioma. MRI revealed heterogeneous, predominantly solid mass in the anterior neck and face region, without airway compression. And no other lesions was found on the moment. On the follow-up ultrasound, growth of tumor was observed, and at 28 weeks, the woman was re-referred for MRI due to the appearance of structural changes in the trunk and limbs, as well to the access to the state of the airways. On the MRI, we saw a deplorable picture. The neck tumor grew more than 3 times, and the entire trunk and limbs were totally affected by multiple nodular formation with intense diffuse restriction. In addition, similar multiple nodular lesions were also visualized in placenta. In the differential diagnosis was high-grade fetal tumor that can metastasize to the placenta. Among them are rhabdoid tumors, various types of sarcomas, and germ cell tumors. We assume that the most likely diagnosis was malignant rhabdoid tumor. We are waiting for results of the pathomorphological examinations. Unfortunately, latest information is not available, but the most likely diagnosis is malignant rhabdoid tumor. This tumor represents a highly malignant tumor of the childhood and can be found prenatally. The most cases demonstrate a non-specific mass lesion, often renal with polyhydramnios and hydrops, but soft tissue lesions also can be in the neck region and have disseminated metastasis. Okay, and second case about 13-year-old boy. A 13-year-old boy without any complaints was consulted by orthopedists and sent for MRI of the spine. He was asymptomatic. He has mild scoliosis and deformity of the clavicle. He has no traumatic injuries. In the spine, MRI revealed widespread lytic and infiltrative changes without significant deformation of vertebrae, as well as areas of the fat signal in individual vertebrae. A hydrophilic mass infiltrated of soft tissue at the level of the neck, chest wall, mediastinum in the back near the affected vertebrae and near the processus spinosus, you can see. On the X-ray, we see deformation of the clavicle and strange structural lytic changes in the clavicle and ribs with periostal reaction. On the T2 FETSAT MRI, we can very hydrophilic mass near the ribs in the neck and in the back. That infiltrate axillary region also and have very high diffusivity. Also, lytic changes was found in the skull and sternum and other bones. On the CT, we found that is cystic and like channels with osteolysis of the bones. So at first we think about sarcoma or histiocytosis, but then I remember another case, a child with osteolysis of the posterior vertebrae, infiltration of the soft tissue of the back, and heterogeneous changes in the vertebral bodies with areas of fatty degeneration and hypervascular areas. That young man has lytic changes, osteolysis of posterior vertebral segment with deformity of vertebral column. So the biopsy was made for this child. I have a video. You can see bloody fluid in a big amount of fluid from processus spinosus of vertebra. On the histopathology was shown markers for vascular proliferation and also lymphatic vascular proliferation. So final diagnosis on the histopathology was Gorham-Stout disease. We also excluded metastatic disease, lymphoma, Ewing sarcoma, histiocytosis, but we can think also about generalized lymphatic malformation. When we speak about Gorham-Stout disease and lymphatic malformation, we need to remember International Society of Vascular Malformation classification. That say that generalized lymphatic malformation and Gorham-Stout disease is a vascular malformation, lymphatic vascular malformation, and tumor-like malformation. So, Gorham-Stout disease is a rare bone disorder characterized by progressive bone loss and proliferation of lymphatic vessels. Proliferation of the other small vessels, hemangiomatosis, can also possible. Affected individuals experience progressive destruction and resorption of bone. Multiple bones may become involved. Areas commonly affected by Gorham-Stout disease include the ribs, spines, pelvis, skull, clavicle, etc. So this very rare disease can be in this case. And the last case is about a 5-year boy with mild respiratory failure and pericardial effusion was found on the ultrasound. He also had thrombocytopenia. On the CT scan, we see bilateral widespread peribronchovascular infiltration and very intensive interstitial edema. Irregular shape involving hydrophilic mass in the mediastinum and in the neck. Here we see MRI and CT scans with very diffuse infiltration and hydrophilic mass in the mediastinum. On the coronal T2 FATSAT MRI, we see lymphangioma-like lesion in the neck. So final diagnosis also was after biopsy and histopathology. It was caposiform lymphangiomatosis. We also at first thought about sarcoidosis, lymphoma, and infection, but only we exclude all these diagnoses, but caposiform lymphangiomatosis, it was first case in our work. We was very surprised. So caposiform lymphangiomatosis is also from vascular malformations, and about tumor. Is a rare type of tumor and vascular malformation that results from the abnormal development of the lymphatic system. Can involve multiple parts of body, especially the lung and chest. Symptoms can start in childhood and include dyspnea, pleural, and pericardial effusion. Disease may include multifocal intra-extrathoracic lymphatic malformation, thrombocytopenia, and coagulopathy. During the chemotherapy, the patient began to feel better, changes in the mediastinum and lungs decreased, and he continues to take sirolimus. I think my case was very interesting for you, and I take a place for next speaker. Thank you very much.
Thank you, Dr. Riebienkov.
Maybe somebody have a question?
Yeah, we can take questions if these cases are really rare and interesting. The vascular anomaly cases as Gorham-Stout disease and caposiform lymphangiomatosis. These are very rare. I've never seen these cases before. Thank you very much. These are rare and we should consider them in the differential, especially that Gorham-Stout disease when we see lytic lesions and when they are lymphatic malformations, we should consider. Are there any questions from the audience? Okay, everybody understood very well. So we can then move to the next speaker. Okay. Next speaker is Daria Varivoda. She is also working in the same hospital. I know her for a long time, and she is actually a radiologist, but she's focused on ultrasound, and she's only doing ultrasound, but she's also trying to do some more MRIs and other studies just for comparison. Yeah, but she's primarily ultrasound. So welcome, Dr. Varivoda.
Thank you, Ali. Thank you for all your close support and all you've done for us. It's a big pleasure. And I'm thankful for your president, Dr. Barnum. Yeah, that will be a little bit rest for you between our MRI cases. First of all, it's Ukraine. It's not only cities, not only people, but also nature. I like our nature because it's wonderful, it's religious. So come to us and we show you. And my cases, the first one is an 8-month boy with macrocrania, no neurological deficiency. On urosonography, we can see the extension of external cerebral spaces. And what shall we think about? Ali, I ask you for a poll.
The poll is on.
Thank you.
Please vote for the answer. What is your diagnosis?
It's easier, must be. Yeah. But in Ukraine, we see this conclusion. So I'm talking about it among of my colleagues.
Okay. So these are the results.
Yeah, yeah, you're right. It's benign condition. Thank you. What should we see? There is no asymmetry. There is no ventricular dilatation. There is the charts are normal. There is no history of trauma. So that's normal. We can we can write the benign enlargement of the subarachnoidal spaces. And the next question, does this patient needs any neurological treatment or follow-up neurosonography? No, it doesn't. So let me just go and under the pediatrician follow-up. So the next case is 2-month boy with seizures and lesion is both kidneys parenchyma. I like to use linear transducer where I can visualize the structure, and this is a perfect moment. So we see some different regions. One region is heterogeneous without any Doppler flow, and some hypogeneous quite without borders, right? So we also, the baby with seizures, we make MRI, and we see cortical and subcortical tubers, also lateral 3 and 1 big rhabdomyomas in the heart, in right atrium and ventricle, and the genetic conclude that there was a tuberous sclerosis complex. And in follow in 6 months, we still see little cysts, yeah, and big one that was heterogeneous, and angiomylopomas in the kidneys, and still rhabdomyomas in the heart, and no changes in MRI. The next case from kidney to kidney is a 6-year-old boy with acute abdominal pain, weight loss, HIV positive. On ultrasound, I see multiply hypoechoic lesions in cortical of kidneys and amount of ascites, fluid. Also, we make MRI, CT, and see a big mass in rectum and sigmoid bowel and the sanded part. There's sites of interception and ascites. Yeah. So the baby was diagnosed AIDS-related lymphoma. From kidney to kidney, the next case. This boy with HIV2 come with conclusion of nephrolithiasis. They saw hyperechoic foci in the kidneys, but I'm not quite agree because it's in the cortical layer, and I also saw something in liver, the same hyperechoic forces, and I thought about that a little bit heterogeneous wall of the gallbladder, yeah, and some shadow, and was not sure. But what can we think about in this case? Thank you, Lynn. You can poll, choose your parent. Okay, can we see the results? Yeah, the first thing about is infection. I think about that either. The first thing that I go to clinician and ask her, I said what I see, and she said that the patient was treatment with tenofovir, and this antiretroviral therapy causes hyperparathyroidism and also proximal tuberous cell dysfunction of nephritis. So they could be some like calcifications of these affected structures. Yeah, but I didn't find any articles that multiply so little in sizes forces in liver with this treatment, during this treatment. But I found another article that the same changes in adult patient without any others clinical features was in out-of-lung pneumocystis nephritis. I said that to our clinicians, I actually don't know the result. He feels good, and there are any others clinical features. So we just see in the future. From classifications, bilateral scrotum ultrasound, we see multiple classifications. There's one conclusion of our ultrasound imagine diffuse testicular microlithiasis. But what the conditions causes such images? You can see it on your screen. If we think about adult patient, in 50% there are signs of testicular germ cell tumor. But in children, we can see it in syndrome patients and infertility and cryptorchism. But the next question, thanks to Ali, we think, does this patient need any follow-up if we see it in a baby, for example, 6 years old? Yeah, we can see it. Yeah, good. You're right. Yes, 1 per year. So I found that the European Society recommends the follow-up until age of 55 if your patient has moderate orthodoxy and testicular atrophy or previous germ cell tumor or family history of germ cell tumor. And the next my case is 16 years old girl with acute myeloid leukemia. She underwent allogeneic bone marrow transplantation, and at 16 days, the bilirubin was high in levels. You should also know that there are early complications up to 100 days of bone marrow transplantation. There are vena occlusive disease, thrombotic microangiopathy, Engraft syndrome, and hemorrhagic cystitis. And the case was really in Friday evening when everybody don't know what they will do on weekends. And they asked to see the abdominal. But what should we confirm or exclude? I see in every of these complications features, and only 2 of them have high of levels of bilirubin. That's Engraftment syndrome and vena occlusive disease. Also, we should see at gallbladder wall thickening, portal wall thrombosis, maybe ascites, hepatomegaly, and also the Engraft syndrome. The major criteria is excess fluid in the lungs and a heart problem, dysfunction of left ventricle. So we also can see it. Yeah, right. Right. And the girl was represented with a thickening of the gallbladder wall and the widening of cystic, ductus cystic and hyalodicus to 6-8 millimeters, a little bit amount of fluid, but no lung effusion and good cardiac function. So that is more like vena occlusive disease, and the stage was mild, and it was resolved in 5 days. So that was my last case. Maybe you have any questions? Or
thank you very much, Dr. Varyvoda. And we can get the questions if there are any from the audience. You can type in the chat box, or you can speak up. We can turn on the microphones. Okay, you can use the QA box. So everybody understood very well, apparently.
Thank you.
And we are actually, there is one question. Do you call benign external hydrocephaly? Okay, do you call benign external hydrocephaly?
Actually, when we put hydrocephaly, our neurologist always ask for a neurosurgeon consultation. I always try to say what is enlargement of extra spaces to patients, always to neurologists, as they could understand. But I think that the most better variant is the first one of supracondyle spaces.
Yeah.
But in radiopaedia, write the hydrocephalus.
Yeah, I know. Like I use the same term. When you say hydrocephalus or subdural, then it becomes more worrisome, which is a benign condition. And yeah, I prefer the same terminology. And also I ask for the father because there's a family history. Usually the father has a big head and the child has a big head too, and they're males, and yeah, they're helpful findings. Thank you. And for the testicular microlithiasis, if there is no risk, family history, or tumoral gene condition, we don't recommend follow-up in Canada. But
Yeah.
if there is a risk, then we recommend a follow-up every year.
Mm-hmm.
And let's see, okay, there is no other questions, so we can invite
Thank you.
Dr. Anastasiia Rusyn.
Hello to everyone. Nice to meet you and nice to be a part. Thank you for making me a part of this occasion. So actually, I would like first to introduce you my home city, Lviv, and the place you should visit there is National Solomia Krushelnitska Lviv State Academic Theatre of Opera and Ballet. So the Lviv is located in the western part of Ukraine, and it is very popular for tourism, historic cultural center. And this opera house is referred to UNESCO heritage, so you should better visit it. So my first clinical case is about patient male, 6 years old, with the symptoms of increased intracranial pressure. When the first MRI was made, a huge posterior fossa tumor was found, and it looks very heterogeneous, with a high variety of ADC levels from low 0.8 to 1.8. And different parts of the tumor reveal different enhancement patterns. Patient started treatment in another hospital, and when he came to us, he was already made a small biopsy, but it was not very informative, and for better prognosis for patient, it was better to remove more than this small part of the tumor. So our differentials was between medulloblastoma and ependymoma. So you can see our MRI scans, and we can see the very huge tumor in fourth ventricle. We can see some nodular, looks like part in the fourth ventricle, and some part of the right hemisphere of cerebellum was also, in fact, infected with this tumor. And on the lower row, you can see the enhancement of these parts, and we can see that very huge fragments of tumor were really good, had really very intensive enhancement pattern. On these scans, I was trying to show you the ADC of that tumor, and we can see the in the central part of the first ventricle, we can see the ADC coefficient of 0.8, and on the peripheral zone, we can see some nodular part that was that present very hypervascular, and on perfusion maps also the indicators of CBV and CBF were very high. Our neurosurgeons were good in deleting this tumor. And also I would like to remind you the subtypes of medulloblastoma firstly, before telling you the pathology report. So we can see that our tumor was very similar to the group 4 in some parts, because it was not really good enhancement of the part on previous slide. You can see that the small part in fourth ventricle was not enhancement, but has no enhancement, but on the peripheral zone there was very vascular. So it was really difficult to make some conclusion only with MRI. But when we saw the pathology report, we were really surprised, because the patient has 2 types of tumor. The one was medulloblastoma non-BNT and non-SHH, and the rest of the tumor was low-grade glioma with post-treatment changes. So I think it was really interesting case, but I have another one. So the second case was about patient male, 11 years old. 11, remember this. So symptoms with congenital absence of odor. His mother was has the same symptoms from her birth, and MRI revealed absence or at firstly, we couldn't say it was absent or hypoplastic, but with the help of the different articles, we really decided that it was absent. Olfactory bulbs and salty with normal pituitary gland, it is really important. And also the patient has bilateral cryptorchidism, decreased volume of testis, scrotum, and penis. Differentials, actually the differentials is really have very high variety of different syndromes, but our focus about on Kallmann syndrome and Bardet-Biedl syndrome. So about Kallmann syndrome, I found a very nice picture, handmade picture of someone who was trying to represent this cycle. The Kallmann syndrome is has mutation in more than 20 different genes, but they can defect the migration of gene RH cells, and so it affects the hypothalamus and reduce the hormone function. So these patients has hypogonadism, and also as there was a failure of bulb there was a failure in bulb formation, so we can see the agenesia of olfactory bulbs and sulci. So on our MRI, I was trying to show you on coronal T2 weighted images that the patient has 2 kidneys. It also very important things, because sometimes it is associated with agenesia of one of the kidney. On the low row, you can see a small volume of scrotum without testis, so they didn't decrease descend, sorry, in the scrotum. And also on sagittal view, you can see a small penis of the patient. What about his head MRI? So we can see normal pituitary gland and deepened anterior fossa, cerebral fossa. On this slide, I was trying to show you that we can prove the absence of olfactory bulb when we are comparing this patient with normal, without anosmia patient. So in normal anatomy, we can see that olfactory fossa is deepened, and also we can see olfactory bulbs and normal sulci. And in this patient, we don't see any olfactory bulbs. Sulci are shallow shaped. So it's really rare syndrome because we can find it only in 1 in 10,000 males and 1 in 50,000 females. It's a genetic disorder, and in this patient it was confirmed genetically. So he has a defect in ANOS1 gene, and it is inherited in X-linked recessive pattern. And the last my case was about patient female with established diagnosis of medulloblastoma on treatment stages. She developed symptoms of increased intracranial pressure. Also in her treatment protocol, she was getting intrathecal methotrexate, and MRI revealed supratentorial enhanced lesions with huge perifocal edema. Our differentials include metastasis, infection, and methotrexate encephalopathy. So I was trying to show you that she was really, had really spread metastatic disease. It was in subtentorial and supratentorial regions. And also we can see not very correct position of the ventricle catheter of the reservoir Ommaya. And around this catheter, we can see some enhanced mass, and it was very suspicious for prolongation for metastatic disease. And also in some follow-up, we see that it was growing, and really were frightened about this perifocal edema, so it was really suspicious for prolongation. I would like to ask Ali about voting. So what you think about this case, and what you think it could be? Voting. And the result? It was really interesting, yes, for you too. Yes, the 31% of people were correct. It was methotrexate granuloma, actually. And I think you were also surprised with this. Follow-up of this patient, our neurosurgeons were good. They just took it, everything, and perifocal edema was decreased. So the patient was lucky. Thank you. Do you have any questions?
Thank you very much. So the catheter was not in the correct place, and what they administered methotrexate and it went into the brain parenchyma, right?
Yes, unfortunately, when she came to our hospital, she was already with this catheter. And when she was getting her therapy with methotrexate, at first she didn't develop any symptoms, so everybody thought that the catheter was working right. But after these follow-ups, we saw that mass, and it was the decision to take it off and to cut it off and to see what is this. And we revealed this very surprised result.
Very interesting. And for the first case that you diagnosed 2 different tumors, one glial tumor and one medulloblastoma, did you consider that this could be an error in the pathology, or?
Actually, we were doing our pathology and it was medulloblastoma with pilocytic astrocytoma, but our friends from Sick Kids sometimes are helping us with with reference of the pathology, and they told us that our pathologies were correct. It was 2 tumors. So
you're collaborating with Sick Kids, right, in Canada?
Yes, we are collaborating about neuro-oncology patients.
Do you have common rounds? Do you have meetings together?
Yes, we have sometimes one meeting in 2 months and sometimes one meeting at months. It depends how many patients we can demonstrate and with time of these doctors who help us. So it's Doctors Rutka, Buffet, Christina Go, and others. They are helping us with these cases.
That's very nice. Thank you so much. So now I would like to welcome Dr. Katerina Rusilo. She is going to be the last speaker.
Thank you very much, Ali. Good evening to everyone. My name is Katerina Ruzhylo, and these are my pediatric radiology cases. So the first case, newborn baby, 18 days, female, conceived by in vitro fertilization with donor ovum. This procedure is legal in Ukraine. Term born by C-section on background of mother's gestational anemia and hypertension with Epgar score from 7 to 8 and no clear evidence of fetal distress. During first week of life, this child presented with rapidly deterioration of neurologic and respiratory function and was transported to intensive care unit. On ultrasound, extensive cerebral edema and thalamic hyperechogenicity were observed. So we did an MRI, and on axial T2 and T1 scans, we saw bilateral extensive symmetric areas of T2 hyperintensity, T1 hyperintensity, involving paralandic white matter, posterior of internal capsules, corticospinal tracts, partially globus pallidum, cerebellar peduncles, and brainstem. And in addition, mildly diffuse increased T2 signal of white matter of both hemispheres was observed. On diffusion-weighted images, we saw bilateral extensive diffusion restriction of previously mentioned areas and of optic tracts too. On these sagittal scans, we see the extension of pathologic signal on T2 and diffusion restriction to the cervical segment of the spinal cord on the observed levels. We also did a mass spectroscopy on 135T, and we saw elevated choline and creatine peaks, reduced Na, and also on several voxels, we saw a strange reverse peak in 1 ppm that may be probably caused by brain chain amino acids. And the final diagnosis that was laboratory confirmed is Marple syrup urine disease. This is a rare metabolic autosomal recessive disorder characterized by error of metabolism of this brain chain amino acids, which are extremely important in energy metabolism and the synthesis of proteins in myelin. And as a result, these patients have 2 pathologic components. The first is intramyelinic edema, due to accumulation of these K acids and water molecules between layers of myelin. And second is vasogenic edema. This is due to disruption of the blood-brain barrier in metabolically decompensated patients. And the diagnosis is made by laboratory and genetic testing, and a few words about differential. Of course, these MR changes in the disease are quite extensive and intensive and diffuse, and they are almost pathognomonic, but in late onset and less severe changes, the differential can include other metabolic disorders, for example, of mitochondrial spectrum. What about this case? Of course, it's quite classical, and the diagnosis was not a problem for us, but it is interesting for us because it's only the 4th documented case in Ukraine and the first case in our institution. And I think that not all pediatric radiology see this case and report this case in their practice. So we're moving now to case 2. It is about infant, 4 months old, who presented with recurrent episodes of respiratory distress, which increased in frequency. He received treatment of pneumonia without positive effect. On chest X-ray, the widening of upper mediastinum was detected, so further CT examination was required. And on contrast-enhanced CT scans, we saw bilateral extensive hypervascular mass with multiple feeding vessels involving all parts and all floors of mediastinum, infiltrating mediastinal fat, involving the posterior wall of trachea, the upper neck soft tissue spaces at the visible level. And also we observed the same hypervascular component involving right adrenal gland. Also, no bone destruction and major vessel invasion were observed. And we had an impression of local intravertebral extension or maybe a local epidural plexus dilatation. Differential diagnosis included hypervascular neurogenic tumor such as paraganglioma, extramedullary hematopoiesis, hemangioma infantile or congenital, and angiosarcoma. Then the biopsy was done, and pathologic reports explained that there were columns of adipose tissue with a growth of tumor having a lobular structure. The lobes consisted of channel vessels of capillary type without signs of cytological atypia. And in immunohistochemical study, tumor cells were positive for CD34, CD31, and GLUT1. And these changes were characteristic of infantile hemangioma. So the final diagnosis was infantile hemangioma. Which is a benign vascular neoplasm that most commonly occurs in superficial head and neck tissue. It is characteristically small or absent at birth with progressive enlargement during first year of life, and then it typically gradually decreases in size. This situation is interesting because it's rather a typical location. For us, it's the first case of such extensive inner thoracic and abdominal infantile hemangioma with such aggressive pattern of distribution. This patient received treatment of anaphylline, and on 3 months follow-up, we saw subtotal regression of size of this vascular tumor and decrease of its vascularity. And also we saw the positive effect on the right adrenal gland. The hypervascular component is almost gone. And the last case, 16-year-old female who presented with constant pain in the left lower part of the abdomen during a week after menstruation. She purported mass in her left iliac region, and on ultrasound, left-sided hematometra and hematocolpus were observed. But ultrasound technicians were not sure if they saw hematocolpus or maybe it was hematosalpinx, so we didn't MRI. In addition, on ultrasound, left kidney was not found, and also no temperature and inflammatory markers elevation were observed. And on this pelvic MRI, we saw the bicorporeal uterus, so duplication of uterus like uterus diadelphys, left-sided hematometra with hematocervix, left-sided hematosalpinx, and right-sided uterus and cervix communicated with normal vagina, and left part of vagina fornix was situated near left-sided uterus, but without clear connection with it. Also mild ascites and several hemorrhagic intraperitoneal and right ovarian inclusions were observed. And on isotropic T2 scans with curvilinear reconstructions, we saw a thin linear band that extended from the cervix area caudally towards the posterior wall of urinary bladder, again without clear connection. And at that point of time in our report, we suggested that it could be a hypoplastic or at least ectopic hemivagina, or maybe ectopic fragment of the ureter. And of course, normal left ureter was not visualized, as well as the left kidney. Of course, these MR changes needed operative correlation, and intraoperatively, left-sided hematometra, hematocervix, and hematosalpinx were confirmed with left-sided cervix external os agenesis. And so the left-sided vagina was not found at all, and previously described linear structure near urinary bladder appeared to be just a fibrous band. Our gynecologists use this classification of European Society of Human Reproduction and Embryology and European Society for Gynecology Endoscopy. This is believed to be more simple and more characteristic of the genital anomalies in females. And if we try to classify this anomaly of our patient, this would be a bicorporeal uterus. And by the way, they refer uterus diadelphys and bicornual uterus in the U3 class. So they mention it as a bicorporeal uterus. So that could be bicorporeal uterus U3, type B complete, and we had two cervix, although the left side cervix was obstructed because the external os of the cervix was obstructed, but the all cervix was normal. So this could be on this classification, class U3B, C2. And also we found such information about Werner-Windley syndrome, also known as HWIRA. This is a rare Müllerian duct anomaly, which consists of uterus diadelphys, obstructed hemivagina, that finally leads to hematometra and hematocolpus, also ipsilateral kidney agenesis, and there can be Gardner duct cysts. Of course, unfortunately or likely, this MR picture of our patient doesn't ideally meet to the findings of this syndrome, but because we didn't have left-sided hemivagina at all, it was genesis, but it was associated with cervix external osteotresia that lead to obstruction, and also this patient had ipsilateral kidney agenesis. So we think that given MR findings probably can represent an atypical variant of the syndrome. And these pictures are of Ukraine, and this is one of my most favorite places in Ukraine. It's National University that is situated in town Chernivtsi. It's rather old and famous university, and it is one of the leading Ukrainian institutions, and it is included to UNESCO World Heritage Site, and I definitely recommend you to visit it. It is worth visiting and seeing. If you have any questions about these cases, or you're thinking about international cooperation with our department, we'll be very happy if you contact us on our Facebook page by the following link. And my colleagues and me, thank you very much for your attention, and we thank Ali for inviting us. It is a big
Thank you, Dr. Rusilo. I think we are having some issues with the microphone, but now, okay, so everything is good now. So there is a question from Dr. Boris Tarasyuk. He is asking if you published any cases in Ukrainian radiological journals.
No, unfortunately, personally, I didn't do that.
Okay. Yeah, I know some
many publications about the gynecology or about these cases, they were not in the journal.
Yeah, we see interesting cases, but it's not always possible to publish them.
Oh, we don't have time or some other problems.
Yeah. Okay. Are there any questions from the audience regarding any of the cases? And I think Gülnar Agayeva is raising hand. You can speak, Gülnar, if you want to. And one of the Janver, like he's a radiologist. He knew the case the last case when you start showing it. He knew that it was HWIRA.
Actually, I don't know if it was HWIRA, because HWIRA is associated with hematocolpus due to obstruction of hemivagina. And in this case, intraoperatively, they didn't confirm the hemivagina at all. It was agenesis. So maybe it's a variant, possible. But we are not, yes, it's possible.
Okay. And there was, I see Boris Tarasyuk, if he's available, Boris Tarasyuk. He is. I would like to invite him to the meeting because I know that a Pediatric Radiology Society was recently founded in Ukraine by Dr. Stanislav Riebienkov and by Dr. Boris Tarasyuk. Is Dr. Tarasyuk, are you here? Turkish Society of Radiology was founded approximately 10 years ago. I'm not quite sure. So we are ahead of you. And it is really interesting to see that I visited Ukraine almost 10 years ago, and Ukraine the medicine was behind Turkey, according to me. Then there was a significant improvement. I observed that. Now you're like ahead of Turkey or even equal to Turkey. You have very good hospitals and you have your own association and everything. So
yes,
it is.
You're right. We can collaborate between Association of Pediatric Radiology of Ukraine and Turkish Association. It will be a great pleasure for us. So maybe.
Yeah, I remember there was, I think five years ago, Turkish Society of Radiology invited Ukraine to our annual meeting, and many radiologists attended that in Antalya. So I think we can start collaborating together. I don't know how. We can publish, for example, you have nice cases, or we can collaborate for these teaching meetings. And thank you for doing this for us.
It was a very nice experience. Thank you.
Yes, thank you for your invitation.
Welcome. If Dr. I think he's having some technical problems. And yeah, so, okay, congrats for the Pediatric Radiology Society of Ukraine. And there are no questions. And thank you very much. And thank you everyone for attending this meeting. And I hope to see you in 2 weeks for our New Year's Day celebration. We are going to have a quiz show, Who Wants to Be a Radiologist show. And until that time, stay safe.
Also, we would like to invite you on our Association of Radiologists of Ukraine that will be held conference in March, I suppose.
In the end of March.
So you can also...
Is it gonna be virtual or on site?
Yes,
Partly virtual or partly offline. So.
And it's in Kyiv, right? It's in Kyiv. Okay,
yes.
Nice. I will try to join.
Please, we are waiting for you.
Okay, yeah. Thank you very much for joining, and I'm closing the session now. Thanks.
Thank you.
Thank you.
Bye-bye.
Bye-bye.
Bye-bye.